The participants can put their video off for a while, if that's okay.
I think their video as well as audio should be off during the MCQ round.
Right. Shrinivas sir is here.
Yes, hello, hi everyone. Hello, Lalit sir.
Yeah.
Good evening, everyone. Welcome to iFocus Online, lecture 166, Retina session 18. And today we have a New Year's Eve special, that is an OSCE and quiz based on retinal examination and investigations. And we have with us our quiz masters, Dr. Prashant Bawankule, Dr. Shilpi Narnaware, and Dr. Shrinivas Joshi, sir. I request Lalit Verma, sir, to briefly introduce them, like they're all very well known, but sir, your audio, sir. Lalit sir, your audio, please. Yes, sir. Yes, sir.
Is it okay now?
Yes.
Yeah, Rolika, Acha Santosh also joined. So it is all efforts of Santosh and our, which, it's made to look like that we have done something. But it's all hats off to Santosh. But I'm happy that you see we have covered 17 episodes, Rolika, and where history taking, diagnostics, all have been covered. So before we go into individual diseases, vascular blocks and arterial blocks, so I think it is prudent that we conduct some MCQs and OSCE examination. And who could hope for better than Prashant Bawankule, because I know Sarakshi, Netralaya, Nagpur has been conducting this not only for us here at Center for Sight, but nationwide. Prashant has been doing this job for a couple of years now. And very happy to see Shrinivas Joshi also joining in this. And I think the format Prashant will announce.
Yes,
and,
I will share my screen.
Yeah, so Prashant, over to you.
Thank you, sir. Shall I share my screen?
Yeah, please.
Okay. So friends, here we are today to have a quiz and an OSCE for you based on retinal diagnostics. Thank you, Lalit Verma sir, Dr. Rolika and Dr. Santosh Onawar sir for this opportunity. Myself, Dr. Prashant Bawankule, my colleague, retina colleague, Dr. Shilpi Narnaware from Sarakshi Netralaya, and the well-known young retina surgeon from Hubballi, Dr. Shrinivas Joshi, will be doing the job together. Well, I will just introduce you to the rules of the today's game. All participants on board to play on Zoom platform. The pattern is we have 20 MCQs. Each MCQ you are given 10 seconds. You have to type the answer in the chat box, and Dr. Rolika will be receiving the answers and she will be computing who has answered right and fastest. Assessment is based on the fastest finger first. After 20 MCQs are over, we decide who are the top 5 performers and they become eligible to play with us the OSCE round. The OSCE round will be face-to-face again on Zoom platform. Here in the OSCE round, we have the pattern is that there are 5 diagnostic images with 4 sub-questions to each one of each image. And you get 30 seconds for each image with 4 sub-questions which you can answer maximum. Well, the marking would be 10 marks for correct answer, minus 5 for wrong answer. And finally, host decision is final and binding. Yeah, so we start with the MCQ round, and the first part Dr. Shilpi Narnaware is going to take you ahead with.
So thank you, sir. Thank you, iFocus, for the opportunity. So let's begin with the MCQ round. So the first question for the MCQ round is, a normal scotopic and photopic ERG with extinguished EOG is seen in, and your options are Oguchi's disease, option B, Best vitelliform dystrophy, option C is retinitis pigmentosa, and option D is Stargardt's disease. And your time starts now.
So one question is that all of them have to be chat box all together or one by one?
Yes, sir.
So the time is up, and the correct answer here is answer B, that is Best vitelliform dystrophy. So let's see, Oguchi's disease, there is negative ARG. In Best disease, there is normal ERG and EOG is affected. In retinitis pigmentosa, the ERG is reduced or grossly depressed depending upon the stage of the disease. And in the Stargardt disease, multifocal ERG is impacted. So coming to the second question, hyperfluorescence in this image seen is due to option A, leakage, option B, pooling, option C, staining, or option D, transmitted fluorescence. Your time starts now. You need to identify the pattern of the hyperfluorescence shown in this image. So the time is over. And the answer here is option B, that is pooling. So if we see that in pooling, there is only increase in the intensity with the time and there is no increase in the size. While these are rest of the 4 patterns which we see during hyperfluorescence. So now coming to third question. Which pattern on octa signifies chronicity of the disease? Option A, C-fan pattern, B, Medusa head pattern, option C, pruned tree or dead tree pattern, and the option D is filamentous pattern. Your time starts now. On octa, which of the following signs signifies the chronicity? So the answer here is D, filamentous. The C-fan and the Medusa head pattern is seen in cases of active CNVM. Filamentous signifies the chronicity of the disease, while the dead or the prune tree pattern signifies it is an inactive CNVM. So now
just for a fun fact, ma'am, for this question, I did not receive even one correct answer except from Lalit Verma, sir.
Okay.
No issues, no issues.
So coming
just to pass time, I was doing it.
Yeah.
In B-scan, wavelength used is option A, 6 to 8 megahertz, option B, 10 to 12 megahertz, option C, 20 to 50 megahertz, and option D, 15 to 20 megahertz. And your time starts now. Various frequencies in various scans. Identify the wavelength used in B scan. So the correct answer is option B, that is 10 to 12 megahertz. So if we see for A scan, it is usually 8 megahertz. For B scan, it is 10 to 12 and 20 to 50 is usually used for UBM. So now coming to the next question. Identify the most common site of break in the figure shown. Option A, 3, option B, 8, option C, 9, and option D, 12. Your time starts now. The white part above is denoting the RD. So yes, the time is over. Let's see what is the correct answer. It is option D, that is 12 clock hours. So it is according to the Linkoff's rule. We all know there are 4 rules which help us to identify the breaks in cases of retinal detachment. So now coming to the next question. All of the following are true statements regarding ERG except. First option is amplitude of A and B wave are measured from baseline. Option B, ERG is recorded in both scotopic and photopic conditions. Option C, A wave is generated from photoreceptors while the B wave from Muller cells. And option D is in cases of CRVO, B wave is affected. Your time starts now. Which statement is wrong in out of the 4 options given here? Time is over. So all the statements are correct except option A, that is amplitude of A and B wave are measured from baseline. Yes, the A wave is measured from baseline to the trough, but B wave is measured from trough to the peak of B wave. So now coming to the next question. MCQ number 7. Which type of fluorescence is this? Option A, pseudofluorescence. Option B, hyperfluorescence. Option C, transmitted fluorescence. And option D, autofluorescence. And your time starts now. The clue is given within the picture. Yes, time is over and the correct answer is option D, that is autofluorescence. It is the innate property of structures to emit the fluorescent light even in the absence of the dye injected. So it is seen in cases of optic disc drusen, astrocytic hematoma, and even in cases of dehemoglobinized blood. So if you see, there is no dye in the blood vessels, and also the choroidal flush is absent. So now coming to the 8th question.
Ma'am, sorry to interrupt. This one request to all the participants, please number your answers. Like, I'm sure that you guys are giving the answers at the correct time, but it would be nice if you can write 5- and 6-, right? Thank you.
Okay. So now coming to the next question. Which investigation would be most useful in confirmation of the diagnosis in this 65-year-old male? Option A, OCT angiography. Option B, ICG angiography. Option C, fundus autofluorescence. And option D, fluorescent angiography. Your time starts now. This is the fundus picture, which is showing the hemorrhage all over the posterior pole with few PVDs. Which is the most useful investigation in this case? So let's see the answer. It is option B, that is ICG angiography. As we see that the OCT features and color fundus photo, they are more in favor of the PCV than a case of a CNVM. And we know that ICGA is considered to be a gold standard in detecting polyps in cases of PCV. So now coming to the second last question of my section, question 9. Best view to localize and see optic nerve disease in B scan. Option A, transverse section. Option B, axial section. Option C, radial section. Or the option D, that is the longitudinal section. Your time starts now. Which view is used to localize the optic nerve or see the lesions compared to the optic nerve? So the answer here is option B, that is axial scan. Transverse scan is used to see the lateral extent, while the longitudinal scan helps in 1 clock hours measurement or the radial measurements in cases of retinal tumors or the tears, and the axial scan, it identify the lesions in relation to the lens and the optic nerve. So now coming to the last question, identify the pathology in this scan. Option A, vitreomacular traction. Option B, stage 2 macular hole. Option C, lamellar macular hole. And the last option, stage 1 macular hole. And your time starts now. So the time is over, and let's see what is the right answer here. It's option D, that is stage 1 macular hole. So these are the normal OCTs according to the gas staging. The central one is the normal OCT, while stage 1, this is stage 2. When the diameter is less than 250 microns, stage 3, you have a PVD attached, while in the stage 3, there is no attachment. So with this, I hand over the screen to Shrinivas Joshi, sir.
Stop sharing. Shrinivas, you are supposed to take over the MCQ round. Next 10. Shrinivas?
Yes, boss. Yes. I'm very much here.
I thought you are in between the case, so try to do a macular.
No. Not that much also. So at the outset, I would like to thank Prashant Bawankule sir and Santosh sir, Lalit sir for this opportunity. So let us start our quiz round. I hope it's very much seen and audible.
Yes.
Okay, so question 1. Diagnosis on fundus autofluorescence. I think Shilpi has already told about the fundus autofluorescence. So see this picture and identify this ring. A, it's a Stargardt disease. It's because of the retinitis pigmentosa. It's a Best disease, or whether it's a Sorsby macular dystrophy. Your time starts now. Yes. So the answer is retinitis pigmentosa. What is this ring called as? Robson-Holder's ring. That is the normal preserved retina at the posterior fundus bordered by an hyper AF ring. So this is the hyper AF ring, which is called as the Robson-Holder's ring, which is very typical feature in cases of retinitis pigmentosa. So let's move on to the next question. 55-year-old male complains of sudden blurring of vision. So what would be the treatment of choice? So observe this carefully. There is an ILM drape sign here, collapse sign, and here also you can see there is some tissue loss. So I think the diagnosis of this is pretty much easy. I have given you 55 years also. Second thing, there is a kind of SHREM, that is subretinal hyperreflective membrane. So to make it more easier, I'll show you this also. The OCTA shows vascular network. I think the answer is pretty much easy now. So let's see what you people answer. Whether it's to observe, intravitreal anti-VEGF, antioxidants, or laser photocoagulation. Okay. So the answer is because the patient has developed, this is the primary feature of MAC tail, right? So MAC tail has developed secondary CNVM. So the answer is intravitreal anti-VEGF. So to make it easy, I showed you the octa feature also in the avascular retina, where you see this neovascular network. Okay. So let's move on to the next question. 43-year-old male on insulin and oral hypoglycemic sent for ophthalmic examination by the physician. BCVA both I showed N666. What would be the management? So first of all, I'll show you the fundus fluorescein angiography. So here you can see this is the early, because we identified this by the bilamellar staining, which is in the early venous phase, right? So now here you can see the veins and arteries are filled, and here you are able to see something here, right? So you have to identify what is this. And here you can see multiple microaneurysms here. Okay. The question is, I'll repeat the question again. So what would be the management in this case? Your time starts now. To observe, whether to give an anti-VEGF, to do a pan-retinal photocoagulation, or to do a focal laser. The answer is again straightforward. Since you are seeing these NBEs, right? So you need to do a pan-retinal photocoagulation in these cases. Unless if you had seen whether there is a focal edema here, or if there is a diffuse macular edema here, then you could have done either a focal laser or a grid laser. But there is no much leakage in the macular area. We are only seeing what is called as NVE, and that too in the late phase where it is leaking. So here we need to do a pan-retinal photocoagulation in these cases. So let's move on to question 4. What is C bar A in this? So see this figure. The C is the length and A is the minimum linear diameter. So what is C bar A in this diagram? Your time starts. Whether it's a macular hole index, MHI, whether it's a THI, which is called as tractional hole index, whether it's a diameter hole index, or whether it is a hole form factor. Your time starts now. Okay. So let's move on to the answer. So C bar B, so the length and the breadth, that is the basal diameter of this hole, is usually described as macular hole index. So A bar B, that is the minimum linear diameter and the basal diameter, is called as the diameter hole index. Now the question asked here is C bar A. So this is the tractional hole index. And then you get D. This is the left arm, this is the right arm, divided by the basal diameter. We call it as a hole form factor. Please remember these nomenclatures. These are very confusing. So just put it up wherever you sleep, beside that your bed or something, so that you keep reading that and you don't forget this. So let's move on to the next question. It's very simple. Diagnosis of the above condition. Look at it very carefully. So whether it's occult CNVM, if it's a PCV, it's a classic CNVM, or whether it's a retinal angiomatous proliferation, it's called as RAP. Your time starts now. So the answer is classic CNVM. Why? Because you can see the lacy pattern in this lacy pattern, but I have not named it as a predominantly classic because it is not occupying more than 50% of the total lesion. If this lesion would have occupied more than 50% of the total lesion, then we would have called it as predominantly classic CNVM. Since it's not more than 50%, so it's just a classic CNVM, or we can call it as minimally classic CNVM. So let's move on to the next question. Which of the following is true for the finding noted in a 10-year-old male? So see this two figures. You can see this. It's again a pretty much direct question. So it's typically unilateral and idiopathic. Is it true? ERG is usually normal and EOG is abnormal. Is it true? To date, the gene responsible is not yet identified, or all of the above. So which of the following you have to identify, which is the true statement in this question. Your time starts now. So the answer is ERG is usually normal and EOG is abnormal. Why? So this is the case of best vitelliform dystrophy. So here you can see the egg yolk stage, and here you can see the scrambled egg stage, that is vitelloreptive stage, you can call it as. And in these cases, ERG is usually normal and EOG is abnormal. What's the gene? Bestrophin gene. I think it's already established. So it's not unilateral, it's always bilateral kind of disease. So answer B is the right answer in this. So again, a straightforward finding, but you have to identify the answer properly. A 35-year-old male, he is basically a photographer by occupation. FFA as depicted here, it's a straightforward FFA. Which of the following is true? This is the most common FFA finding. More than half of the eyes develop permanent reduced visual acuity. Early focal laser may help. Oral steroids are found to be beneficial in this case. None of the above. Write down your answer carefully. Your time starts now. Okay. So the answer is E, none of the above. Why? This is not the most common FFA finding. Most common FFA finding is ink blot pattern. It inks and it blots again. So that's the ink blot is the most common FFA finding in case of CSCR. Early focal laser might help. No, because you can see the lesion is very close to the fovea. The PDT can help, or the micropulse laser can help in these cases, not the normal focal laser. Oral steroids, definitely not. You all know steroids are contraindicated in cases of CSCRs. And so the only answer left is none of the above. So it's the smokestack pattern of the CSCR what we are seeing here. So let's move on to the next question. Which of the following is true? Again, a pretty straightforward B-scan put up, but choose the answer properly. It's the least common primary intraocular malignancy in adults. Involvement of ciliary body is not an indication for enucleation. Brachytherapy may be used for tumors more than 20 mm in basal diameter. Collar stud appearance is attained when it breaks through the Brooks membrane. So be attentive towards the options given here. And your time starts now. So you can see this. What is this answer? Choroidal melanoma. It's a most common primary intraocular malignancy, right? So involvement of ciliary body is an indication for enucleation. So brachytherapy is usually used for less than 20 mm in basal diameter. And definitely the collar stud appearance is attained when it breaks through the Brooks membrane. So which of the following is true? The D. Answer is D. The collar stud appearance is attained when it breaks through the Brooks membrane. So moving to the last two questions, you can see these ERG photographs, right? I'll explain it to you. This is the scotopic 0.01, 3.0, 10.0. You see the waves are almost extinguished. You see the photopic again extinguished, but the photopic flicker picks up some waves. Okay. So the question is again straightforward. The ERG pictures are straightforward. So let's move on to the question. As per the ERG findings, which of the following is false? Again, please pay attention to the options given here. The conditions can be inherited through several inheritance patterns. Night blindness is the earliest symptom. Visual acuity may remain stable despite severely constricted visual field. The clinical finding of the bony spicules and the chororetinal atrophy is virtually the pathognomonic of this condition. So your time starts now. So again, the question is pretty much straightforward. It's a case of retinitis pigmentosa. Here you can see the cone is almost abolished, but the rod, we can see some function in the photopic 3.0 flicker, right? So the rods, the cones are still there. So it's basically a cone rod dystrophy because photopic 3.0 is also almost extinguished. So the condition can be inherited through several inheritance patterns. It's true. Night blindness is the earliest symptom, true, unless it's a cone rod dystrophy. So this is a rod cone dystrophy. In cone rod dystrophy, the earliest will be difficulty in near vision, especially the kids. Usually when they go to the school, they identify that they are not able to read properly. Visual acuity may remain stable despite severely constricted field. Yes, unless there is a macular atrophy. But the answer is D. That is the clinical finding of bony spicules and chororetinal atrophy. No, chororetinal atrophy is not the pathognomonic of RP. What is the triad? The triad is, what is the triad? It's the, yes, waxy pallor of the disc.
Waxy pallor disc, bony spicules,
Yeah.
arteriolar attenuation.
Very good. Fantastic, Gitanshu. So the chororetinal atrophy is not the pathognomonic of this condition. So the false answer is D. The answer is D. So let's move on to the last question. Again, a pretty much straightforward 32-year-old female, I'm stressing here female, presented with similar findings in both eyes. What does these arrows signify? Whether it's a staining, pooling, leakage, and a window defect. It's a pretty straightforward. I would appreciate if you can tell me the diagnosis of this condition also. Your time starts now. Wait until the time is over. Wait until the time is over. Yes, Nishi wanted to say something. So the answer here is pooling. So what is this stage called as? Divya?
VKH, sir.
Yeah, so it's a case of acute VKH where we usually don't see the sunset glow fundus. And here, what is the classic FFA finding described as? You can see the pooling, multiple pooling patches here. So what is this called as? It's also called as starry sky appearance of the FFA, which is again seen in cases of Vogt-Koyanagi-Harada syndrome. So thank you very much for the patient listening.
Okay, thank you, Shrinivas, for wonderfully conducting and explaining the students each important question. So I think, Rolika, are we ready with the, I will share my screen meanwhile. Okay.
Yes, sir.
The beauty which I liked was the answer. So you have, it's a very educative kind of.
Yeah, very well
Yes.
elicited.
I would like to thank my fellow also who has helped me in this, Dr. Rajeshri Salvi. Acknowledge to her name also. Thank you.
But you explained all the answers very nicely.
Yeah. Thank you, sir. Thank you very much.
And I must say that all the participants, so
Yeah, who
many
are the
of you have
finalists?
answered well. Yeah, I have the finalist list,
Yeah.
and I want all those 5 to just put on their video if possible. So Dr. Soni, Dr. Pratibha, Dr. Divya, Dr. Saugata, and Dr. Nishant.
Okay.
Many of them answered correctly. That's pretty impressive. But these are the ones which answered fastest 5.
So congratulations to these 5 guys who are made it into finals. So now, Rolika, who will be the person who will play first?
So however you decide, sir, we can go with Dr. Soni. Why not?
Okay, Soni, you can come live, get your videos on. And now let's all of you hear first the rules for the OSCE once more. We are going to play 1-to-1 on a Zoom with these top 5 finalists. Rest all the participants are supposed to keep their video as well as audio inputs off. For each participant each finalist who is going to participate, there will be a set of 5 images, and each image has 4 questions which need to be attempted within 30 seconds. Assessment would be done this way. Each image has 10 marks. Each question has 10. Each image has 10 marks. The correct answer for all the 4 questions will be 10. If you give wrong, it will be -5. Rather, it is 50%. You can make it like that. So, Soni, are you ready there with us?
Yes, sir.
Which set would you like to? There are 7 sets. You are the first one to choose. Which one do you want?
Set 3, sir.
Set 3 for you. Okay, here we go with the set 3. Remember once more, there are 5 images of 5 different diagnostic instruments which we use in retina. Okay, for each image, there will be 30 seconds. Within those 30 seconds, there will be 4 questions which you need to answer within those 30 seconds. If you know the answer, do answer immediately. And you have to speak to me. You don't need to type on the chat box. Now you have to be audible, and I would be hearing it, and I would be marking your points. Okay.
Yes.
So this is your first question. Here, 30 seconds. Describe classical fundus appearance and the probable diagnosis. You can say pass because you have 30 seconds.
Pass.
Okay. Ethnicity and presenting complaints. Naturally,
Pass.
no. Inheritance, you will not be knowing. What is Mizun Nakamura phenomenon?
Oguchi syndrome.
Yeah. So what is that phenomenon? You can describe me the phenomenon. What exactly it happens?
Sir, firstly, the fundus will be pale. After giving 20 minutes of dark adaptation, again the fundus takes up the normal color.
That's great. So of the 4 questions in 3.1, that is first image, you score 2.5 marks. Okay, fine.
Okay.
So let's understand the answers meanwhile. So this was a classic called washed out appearance, which is suggestive of Oguchi's disease, which is classically seen more commonly in a Japanese ethnicity, and they complain of night blindness. And the genetic pattern is autosomal recessive, and the gene are SAG and GRK1, which you should remember. And what is the phenomenon? It is if patient sits in the dark for an hour, retina looks normal and the night blindness also disappears. Okay, now we are ready. Are you ready for the second image?
Yes.
Get ready. So this is a B scan. Just now Shrinivas delved upon it. First question, diagnosis.
Sir, choroidal melanoma, sir.
Okay.
Collar-stud appearance.
Describe the classical ultrasound features of this.
Collar-stud appearance.
Yeah, but describe what is the surface reflectivity, the internal reflectivity, what is the diagnostic
The
feature?
internal acoustic, like.
Yeah. Come on, read it.
Yes.
So it has.
We have a low absent of reflectivity in when we.
Okay. Sorry, you exhausted your 30-second. Well, you can attempt the next two questions, which was with this image, because you took more time. But we will not be giving you marks. What are the features which are suggestive of local spread? Are you aware? On an ultrasound? Okay, fine. And what are the common mimickers? Can you tell?
Choroidal hemangioma.
Okay. It's a flat lesion. Okay, fine. Let's see through the answers. You answered correctly. It is a choroidal melanoma, which is the most common intraocular tumor seen in adults. See, this is a solid mass. Whenever you have to describe a lesion, you should remember you have to describe this way. You have to say the high surface reflectivity, where the A scan meets the first surface. So it has a high surface reflectivity. Then you have to describe the internal echoes. These are moderate to high. And this is an acoustic shadowing, which is classic or almost diagnostic of a melanoma. Okay. So this is how you differentiate. Well, if you do an A scan, you can also see internal blood flow, which can also help you from differentiating it from metastasis. But choroidal excavation is one of the most important diagnostic feature. Well, regarding the spread, scleral infiltration is seen as low reflectivity at the level of scleral coats. If there is extrascleral extension, you might see a nodule beyond the scleral shadows. And if there is a spread along vortex vein, you will see a scleral discontinuity over there. And the fourth question was, which are the mimickers? These are the ones, melanocytomas and choroidal schwannomas. Well, now are you ready for the third image?
Yes.
Okay. This is a FFA. Yes. Identify this classic FFA pattern.
Flower petal pattern.
Correct. In which condition is it seen?
Macular edema.
Okay. And fluid accumulation is seen between which layers?
Outer nuclear layer and.
Correct. Apart from this, which pattern is seen in Irwin gas syndrome? And when? Okay, you can say pass.
Pass.
Okay, last question. How to differentiate it from a diabetic macular edema? 2 or 3 clues? Pardon? Okay, you said pass. Yes. So let's move back to the answers in these images. Yes, you correctly answered. It is a classic petaloid pattern on a FFA, and which happens because of a Irwin gas syndrome. Typically, Irwin gas syndrome does not manifest immediately in a post-operative period, but 3 to 4 weeks after an uneventful surgery, and then there is a loss of vision. And here fluid classically accumulates between outer plexiform and inner nuclear layer. The other pattern which you can have is a honeycomb pattern, which is usually seen outside perifoveal region. And how do you differentiate a diabetic macular edema versus Irwin gas syndrome in a post-operative patient? Well, here the classic pattern is petaloid. This staining will be present in a case of Irwin gas syndrome. Also, in a DME, you will have associated diabetic changes, say like you can see microaneurysms or new vessels and something like this. So now we move on to the next image. Are you ready there?
Yes.
Okay. This is a young boy with poor vision where a OCT is being shown over here. Look at it carefully, and here starts your question. Identify the condition and describe the OCT. Okay.
So there is hyperreflective shadowing in the vitreoretinal interface.
No, I think you are going wrong. You would like to pass. Meanwhile, you might get a clue. Presenting sign and fundus picture you seen in such a case where you are not showing, you can see most of the layers of the retina. I have given you almost a clue. Okay. Sorry, you exhausted your time. So we'll see this question. Okay. This is classic case of foveal hypoplasia where there is a preservation of multiple inner layers and absence of foveal deep. Let's go back to the OCT. You can see all the layers. Usually, if you see when there is a foveal deep, and all these layers, inner layers of the retina, thin out at the place of foveal avascular zone. So if you see these layers passing across, it is a classic case of foveal hypoplasia, and it's almost diagnostic. And the presenting feature usually is a nystagmus, and then on fundus photograph means imaging, what you see is the absence of macular xanthophyll pigment, diminished foveal reflex, and abnormal macular vascular pattern crossing foveal avascular zone. Usually the retinal blood vessels do not cross the foveal avascular zone, while it might see crossing. And you have a irregular absent FAZ. And the clinical means features, say, how do you treat it, is refractive correction and low vision aid. So let's move on to the last question of this. 78 years old male presented with gradual diminution of vision. 2010 picture of this image and 2015. Well, identify the disease.
Age-related macular degeneration.
Correct. Which variant?
Dry.
Yes, good. Geographic atrophy. This is a sequential images, which what is it suggestive of? 2010 and 15, there is a small difference. Look at the image properly. Age, I give you a clue.
Pass.
Okay. Genes indicative of poor therapeutic response. When you are managing case of AMD, which are the genes implicated with poor therapeutic response?
Pass.
Okay. Fourth, constituents in AREDS2 formulation. You have exhausted your time, but we will like to hear from you.
Zeaxanthin, lutein.
Okay. Partly you have answered. So let's see through these answers. It's a classic case of a geographic atrophy. And if you go back to the image, whenever you see hyperlucence over here, along the borders of a hypolucence on a fundus autofluorescence, it suggests it is about to progress, suggests it is a sign of progression. And the genes implicated with poor therapeutic response in cases of AMD is ARMS2, CFH, and C3. And this is the constitution of AREDS2, which you should all remember: lutein, zeaxanthin, and omega-3 fatty acids. Well played, Sonia. So let's see what was your total marks. You have scored in total 11.25 out of 50 marks. Okay. So now we will move on to the next participant. Yes, Rolika, who is going to be the next participant? Set 3 is already played.
Yes, sir. So the next participant will be Pratibha.
Pratibha, are you there with us? You can get your audio as well as video input on.
Yes, sir.
Pratibha, set 3 is already gone. So which set you would like to choose amongst the 7? But for 3.
Set 1, sir.
Set 1. Okay. Here we go with the set 1. Okay. Again, the pattern is going to remember every image has only 30 seconds within which you have to answer 4 questions maximum. Okay. Ready?
Okay, sir.
Identify. Yeah. Diagnosis. Color photo.
Papilledema, sir.
Oh, look at it carefully. Do you see some lines emanating from disc?
Angioid streaks.
Correct. We take it. Systemic association and underlying pathology.
Paget's Stargardt's.
Pardon?
Paget's disease, Stargardt's disease. Ehlers-Danlos.
Okay, we take it. And underlying pathology?
So break in the Brooks membrane, sir.
Correct. Differential diagnosis of similar looking lines on the fundus.
Sir,
another differential. Correct? Please. Oh, you exhausted your 30 seconds. Fine. What did you answer?
Sir, ophthalmomyiasis.
Okay. Okay. Let's move on to the next question. Commonest vision threatening complication. You will not be getting marks for this, but you can attempt it. In a case of angioid.
Detachment, sir.
Angioid streaks.
CNVM, sir.
Correct. CNVM. But let's see through the answers. So this is a classic cases of angioid streaks which emanate from the disc and go radially, unlike and this happens because of excessive deposition of calcium in Bruch membrane, which leads to its break. And the diseases which are associated are pseudoxanthoma, osteitis deformans, fibrodysplasias like Ehlers-Danlos, MAF1, acromegaly. And the differential diagnosis is choroidal rupture, where you should remember it is concentric to the disc, while angioid goes radial to the disc. And the fourth is commonest complication is CNVM. So now let's move on to the next set of questions. Describe the classic FFA and what it suggests.
Sir,
Come on, we had last question from Shrinivas.
microadolescents.
No.
Pass, sir.
Difference in staining pattern of soft and hard drusense.
Sir, leakage.
Yeah, which type?
Wet will leak it. Wet will, soft drusense will leak.
Okay, we take it. Which type of drusense are more prone for developing CNVM?
Wet type of drusense. Soft.
Soft, I take it. Okay, fine. You have exhausted your 30 seconds, dear. But we will have the last question, which you can attempt, though not marked. Differentiate dry ARMD with Stargardt's disease. How dare they always look almost similar when you see the flecks on the retina? Can you? Any points?
Sir, silent choroid.
Okay. Clinically, I mean, yeah, I take it. Stargardt's disease, you answered well, but clinically, fine. Let's see through the answers. Starry sky appearance. This is because of basal laminar drusense, and the other places where you see starry sky appearance is VKH and multifocal CSR. So you will be seeing the whole black against it, multiple white spots. This is the difference. Soft, you see hypofluorescence initially and then stain in late phase, while hard are hyperfluorescent. The drusense which are more likely to progress to CNVM are soft drusense. You answered right. The other variant is confluent and the drusenoid PEDs. And this is the difference. Dry AMD versus Stargardt's disease, you should remember. Okay. Clinically, you should be aware. Now, next question. This is a OCT. Your question. What does the OCT show? Hello?
Epiretinal membrane, sir.
Correct. Causes of epiretinal membrane.
Sir, post-surgical chronic inflammatory, anything chronic inflammation.
Commonest,
Trauma.
Commonest, idiopathic. Okay, we take it still. How can an early membrane be appreciated on ophthalmoscopy clinically with an ophthalmoscope?
Cellophane maculopathy, it's a shining membrane over the macula.
Any particular light you will use?
Red free?
Yes, correct. So we take this answer. And the fourth question, we have exhausted 30 seconds. Here is the fourth question. Dyes to visualize. You can attempt. You are not getting marks, but you can attempt. Which dyes help you in better visualizing?
Sir, fluorescent.
Intraoperatively, I should be more specific, I believe. Okay, let's see the answers. So this is a epiretinal membrane. The causes you elaborated well, enumerated well. And yes, red-free light when you are doing a direct ophthalmoscopy is the easiest way of looking at it without having heavy gadgets with you. And tryptophan blue ICGs are the dry intraoperatively, which you use to visualize these membranes. Now, this is the fourth image for you. This is the first question for you. Diagnose and what is the characteristic A-scan feature of this condition?
Sir, PVD, sir.
Oh, wrong. See, it's a biconvex shadow.
Subhyaloid hemorrhage.
No. Okay.
Pass.
How to differentiate between primary and secondary disease associated with retinal detachment? So it's a case of a choroidal detachment. So how do you differentiate between primary and secondary? Okay. What will be the cord-like band seen running across the membrane in a case of a, I'm giving you now the answer, that is serous detachment, choroidal detachment. Fine. You have to pass and differentiate between types. Well, we hear it. It was a case of a choroidal detachment. It's a biconvex structure. Convex structure from ora to equator usually does not encroach to the posterior pole. And the classic sign on an A scan is a M spike on a scan in a serous detachment you see. Now you can have a choroidal detachment secondary to RD. If it is secondary to RD, the RD height goes on decreasing. While if it is a primary choroidal diseases, then the secondary RD increases in height. That is the way what I wanted. And it is the vortex when which stops the progression from posterior to means anterior to posterior side, which is seen as a band into that convex shadow. And the type of it, how do you differentiate the two types of choroidal detachment, serous versus hemorrhagic? In hemorrhagic, you have multiple dot-like moderate to highly reflectile echoes, while it is a echolucent in a serous detachment. Now coming to your fifth question. Yes, what is shown in this image?
CMV.
This is an octa. Okay. Diameter of a foveal
500
avascular zone.
microns.
Okay, correct. Blood supply to the foveal avascular zone.
Choroidal blood supply.
Correct. And what is the importance of foveal avascular zone having not vessels there? Why
So,
do
cones are more
no, why do they not have blood vessels? There must be certain specific reason.
pass.
Okay, let's see. Answer. So it was on an octa, you could see an enlargement of foveal avascular zone, and you answered correctly. What is the size is 500 microns. Choriocapillaries is where it gets its blood supply from those layers in the foveal avascular zone. And this is devoid of blood vessels, so that there is no blockage of the light which moves to the photoreceptors. And that's why you get the cleanest of the vision there. Well answer, well played you. And you score 15 points out of 50. Well played. Now, Rolika, who is the next participant?
So next we have with us Dr. Divya.
So Divya, are you there with us? 1 and 3 is gone. Divya, you have to be fast.
Sir, 2.
Set 2. Okay, we move to the set 2. We are going to be a bit faster. Okay.
Yep.
So identify the section and the classic sign shown.
Sir, coronal section, teardrop sign.
Okay. Name the bone involved.
CT scan.
Pardon?
Inferior orbital floor fracture. Orbital floor.
The name of the
orbital
bone.
floor.
No, name of the bone. Okay, let's move. Which nerve and artery is most likely to get injured during such injuries?
Infraorbital nerve and artery.
Correct.
Infraorbital nerve and artery.
Proposed mechanisms. You can give proposed mechanism of such a teardrop. Okay, we move ahead. It's a coronal section where it is a CT scan showing a teardrop sign, and it is the orbital surface of maxillary bone which is weakest, and that's why it gives away. And the commonest artery and nerve which is likely to get affected in such injuries is infraorbital nerve and artery. And the proposed mechanisms are hydraulic and buckling theory. Well played. Now let's move on to the next image. Can you see this image? Now,
yes, sir.
Ultrasound features. Describe the ultrasonic feature of this lesion which is shown there with a black arrow.
Acoustic shadowing. Acoustic shadowing.
No. Okay.
Pass.
Diagnosis. Okay.
Pass.
Caused by which parasite? I give you a clue.
Neurocysticercosis. Neurocysticercosis.
But how can it be neuro? You are right. Cysticercosis. Neuro, it cannot be.
Tinea solium.
Yeah. Okay. And treatment?
Pass.
Okay. Let's see through the answers. Well, how do we define the lesion? See, there is you see a circular lesion over there, which has a very high, dense, highly reflectile, reflective lesion inside this cyst. It is classic of cysticercosis, be it anywhere. So this is not neurocysticercosis. It's into the muscle belly. Okay. And so cysticercosis was the thing, and the parasite is Tinea solium. And what is the treatment? Oral albendazole 15 milligram per kg for 4 weeks along with steroids. Now next image. Okay. This is a OCT picture, I'm sure. Identify and stage the disease.
Macular hole is stage 4, sir.
Correct. What is the commonest cause and most common pathogenic mechanism?
Retromacular traction and idiopathic.
Correct. Slit lamp sign. How do you diagnose? Very good. Treatment.
ILM peeling, internal limiting membrane peeling.
Okay, great. You answered well. You answered perfect this particular question. So I don't need to elaborate further. So let's move on to the next question. Okay. So see the image. What is this classical FFA pattern?
Starry sky appearance.
Look at the peripheral vessels here. This area. I would like you to again bring it to your notice. See the choroid
Pass.
beyond that. Okay. Histopathological reason for this dark appearance of choroid.
Pass. Pass.
Okay.
Silent choroid, sir. Silent
Correct,
choroid is
correct.
start
I take it. I
disease.
take it. Hereditary
Autosomal
pattern of this
dominant.
disease. Hereditary
Autosomal
pattern.
dominant.
Okay, wrong. Mutation of which gene is up in this case? Okay, fine.
Pass.
Okay, let's see through the answers. Well, it is a classic silent choroid where you do not get a choroidal flush, which happens in a case of a Stargardt disease. And it happens because of presence of lipofuscin-like material in RP, which blocks choroidal fluorescence. It is autosomal recessive, and this is the gene which is implicated. Now let's move on to the last set of image for you. Yes, your question, identify the investigation.
ICGA.
Correct. Describe the ICGA finding of this particular lesion.
Hyper, sir, it is late phase in
Hypersenescence. Yes, correct. I take it. Role of ICGA in CNVMs. In which, what
in occult CNVM.
Correct. I take it. Classify the lesion depending upon classification of the lesion depending upon the ICGA patterns of a CNVMs. What are the three types?
Occult CNVM.
No. Okay. Let's move on to the answers. Well, this is ICGA. Why? Because you see a black disc and a prominent choroidal vessel. The other investigation where you see a black disc is a FA, fundus autofluorescence. And you get a hypersenescent membranes, which is suggestive of CNVM. And the diagnosis, it helps you in diagnosis of a occult CNVM. It helps you in delineating the extent of the membrane and also sometimes helps you in picking up a feeder vessel. And based on hypersenescence, the membranes are can be of three types: hotspot or a focal CNVM, which is less than disc diameter, plaque, which is more than 1 disc diameter, or a mixed variant. So well played. And so
Next
you
we have
scored
with us
21 marks. Very good.
Sorry.
So the next, who is the
How
next?
many marks I didn't hear?
No, 21. So
Okay,
Rolika, you
thank
have to move on to the next participant. Next.
Yes, sir. That is Dr. Saugata.
Doctor
Saugata Putar.
Swagata.
Could you-
Swagata, are
Saugata.
you there with us?
Yes, sir. Yes, sir.
Yeah. Okay.
Select 1, 3, and 2 is gone. So which one you would like to play with? We can't hear you.
It's 7, sir. 7.
7. Okay. Let's move on to the set 7. Be ready. And you need to be more louder. I can't hear you so well. Okay.
Can you hear me?
Yes. This is first image. Diagnose the disease.
Racemose hemangioma, capillary hemangioma.
Capillary. Okay. Hereditary pattern of this disease.
Autosomal recessive.
Okay. Typical features on a FFA.
Pass.
Okay. Syndromes associated with
Hornindel lippy. DHL syndrome.
Wrong. Okay, let's see through the answers. Well, this is racemose angioma. And it's a non-hereditary phakomatosis. And the classic thing is, in spite of seeing such a angry looking vessels and the lesions, vascular lesions, they do not leak on a fundus fluorescein angiogram. And the syndrome which is associated is Weber-Masson syndrome. Well, let's move on to the next image. Yeah, this is a ultrasound. Identify the scan. Which scan is being used?
Sir, USG ultrasound B scan.
Okay, that I have already said. Which section? Which section? Let's move on to the next question. Typical feature of the lesions shown there.
Sir, hyperfluorescent lesion is probably consisting of optic nerve head astrocytoma.
Oh, okay. Okay. Minimal size of the foreign body and distance. It should be away from a codes to pick up on a B scan. It's a foreign body image. Okay. Come on.
2 millimeter.
Okay, wrong. What is the initial space not seen on a contact B scan called as? You cannot see beyond this when you do a contact B scan. So this is called, what is it called?
Pass, sir. Pass.
Okay, let's see through. So this is a case of a IOFD, and optic nerve which you were talking about is basically because of the after shadows. Okay. So how do you describe it? Is echo-dense signals which persist in spite of low gain, and shadowing is classic of a foreign body or a calcification like things. And the minimum distance is 0.2 millimeter when you can pick up a foreign body. And the initial space which is not visible on a contact B scan is called dead space. Let's move on to the next image. This is a OCT image. Look at it carefully. OCT finding and diagnosis. Read the OCT for me. Look at the fovea properly. Can't hear you. Be louder.
Posterior highlight is there, and in the outer segment there is a acoustic shadowing in the outer segment of the
Diagnosis.
Yes.
Diagnosis.
Diagnosis probably this could be due to solar retinopathy or.
Correct. You have answered the latter part, right? History. What would we expect in a history?
Laser light exposure, anything like that.
Okay, fine. Fundus autofluorescence, what you will get? You have exhausted your time, but I'm giving you this one question extra. Come on.
I will get hyperfluorescence. Block fluorescence, like actually.
Pardon?
I will get block fluorescence, hyperfluorescence.
Okay, we take it. The fourth question will not mark, just you can attempt. Treatment.
Nothing, observation, sir.
Great. So focal disruption was seen at the level of subfoveal RP and outer retinal bands of the normal, and that is how you will see. The rest is all normal. You have seen focal disruption, and this is classic of a solar eclipse macular bone or a solar retinopathy or a photic retinopathy. And there is a classic history of solar eclipse or a welding light or a laser exposure. And how do you describe an autofluorescence? Well circumscribed hypoautofluorescence surrounded by a ring of hyperautofluorescence, and treatment, naturally no treatment. Coming to this fourth image for you.
Yes, sir.
Yeah. Identify the pattern of DME shown on this.
Ischemic maculopathy. Along with it's a mixed ischemic and exudative maculopathy.
Okay. Give the ETDRS definition of CSME.
CSME, sir, presence of hard exudate within 500 micrometer of the fovea, or presence of retinal thickening or retinal thickening.
Correct. I take it. Management of DME options.
Whether it is involving or not involving. If it's center involving, then I will look for the vision, like if the vision is, and also OCT, there is OCT and FFS classification. If there are like spongiform or cystoid, then I will go for, and the vision is less than 6/9, then I will go for anti-VEGF injection.
Correct. Name some studies showing the role of anti-VEGFs in DME.
Okay,
because
sir,
your questions were longer and answers were longer, I give you extra time. Some studies showing role of
DRCR study.
Okay. Specific to molecules. Okay, let's move it. We are here with the answers. It's a focal diabetic macular edema, and this you described well, CSME definition. And the treatment options you should say is focal lasers and injections like intravitreal, either steroids or anti-VEGFs. Correct. And these are the various studies which you are done for various molecules which I have enumerated here. Okay. Now the last image for you.
Okay, sir.
Identify the imaging modality or the investigation.
ICGA.
Okay. Excitation and emission wavelength used in this.
Excitation is around 520 and emission is around excitation is 480.
Detect. Okay, the investigation is basically fundus autofluorescence. So I will give you a clue. It detects pathology at which level?
RP Brooks.
Correct. And fundus autofluorescence happens because of which pigment?
Because of the hemoglobin in the and also the melanin and lipofuscin, melanin and hemoglobin.
Okay, I take it. So the answers are, this was a case image showing fundus autofluorescence, and the excitation and this field wavelengths shown are given here, and it affects it picks up the diseases which affect retinal pigment epithelium, and it is the lipofuscin which you should remember predominantly. First answer.
Okay.
So now the last participant is there, and you scored 16.25 marks. Okay, well played. So who is the last participant?
Dr. Nishant.
Nishant, are you there with us?
I don't see him. Yeah, Dr. Nishant, please come online.
Yeah. Which set you would like to select? Nishant? Hello.
Yeah.
Set number 5, sir. Set
Can't
number
hear,
5.
Nishant.
Say it again.
Hello.
Nishant, your audio is not clear. Could you please keep the phone closer to you so that we can hear you?
Set number 5.
Set
Okay.
number 5. Okay, but you have to be louder, otherwise you will miss upon your marks. Okay.
Okay, sir. Okay.
Here we are there. Come on. Image 1. Young patient with occasional headache presented with this fundus. Your first question. Identify the condition.
Pseudopapilledema. Pseudopapilledema.
Okay, I take it. Findings on perimetry. Can you be more specific?
Bearing of blind spot.
Okay. Confirmatory investigation to pick up this pseudopapilledema.
CSF pressure.
Confirmatory.
CSF pressure.
I want ocular investigation.
Perimetry.
Okay. So we have exhausted your 30 seconds. And the fourth question was, what was the treatment for this condition? If you would have, what is your clinical diagnosis? Come on, tell me.
IIH. This is IIH.
No. Come on. There is a nodular swelling. If you look at the disc, there are nodular swelling. So if you have a nodular swelling like this, it is classic of a optic nerve head drusen. And so your answer was correct. Perimetry, you get increased blind spot, and B scan is diagnostic, where you can pick up on a lower gain as well. You can see highly reflective structures at the optic nerve head. And treatment is none. You don't need any treatment for this. So the second image for you is this B scan. Your first question, characteristic B scan feature and why is it seen? Can you pick up the character? You see the arrow over here, black arrow. I'm giving you the clue. This is optic nerve head.
Sir, posterior scleritis.
Yeah, so what is that sign called? Correct.
T sign.
Correct. I take it. Diagnose the condition. It was, you have already answered. Systemic association of this particular ocular condition.
Systemic.
Okay, you are exhausted 30 seconds. We'll run through it. What is pulse therapy?
3 injection methylprednisolone 1 gram.
No.
Given.
Okay. Let's see through the answers. It was a classic case of a T sign. T sign happens because of Tenon's widening, which continues with optic nerve shadow, and that's why you get a classic effect. And it happened because of scleritis. The systemic association can be rheumatoid arthritis, ankylosing spondylitis, rigors, PAN, SLE. And pulse therapy is used for intravenous use of immunosuppressives and steroids so that you decrease the need of systemic side effects of this all drugs. Fine. Let's move on to the next image. Your first question, most probable diagnosis. Yes, Nishan?
Pass, sir.
Okay. 3 patterns which you see on FFA. This is a CNVM. I give you an answer. 3 patterns which you see on FFA of a CNVM.
Classical lacy pattern. Classical lacy pattern. Late leakage, and mixed pattern.
Okay. Okay. Let's see. What is the treatment options?
Treatment option, anti-VEGFs.
Yeah.
And we can do photodynamic therapy.
Any 2 molecule and 1 recently launched molecule of anti-VEGF. I get
Brolucizumab.
And any previous 2 molecules? Any 2.
Avastin.
Name no, I need a pharmacological name.
Bevacizumab.
Correct. And
Bevacizumab, ranibizumab.
Very good. I take it. So here is the question. This is a classic FFA showing CNVM. It can be on an FFA classified as classic, occult, or mixed, or on the location as foveal, juxtafoveal, extrafoveal. Well, treatment options, you spoke only about anti-VEGF, but yes, PDT and anti-VEGF is what you should answer. And the previous molecules like pegactinib, bevacizumab, ranibizumab, aflibercept are available, and the new kid is brolucizumab. This is how you should answer. Never use the market name. You should tell the pharmacological name. Okay, now this is OCT over here. Identify the condition and commonest quadrant where you see this optic nerve head problem. I give you a clue.
Optic nerve head problem.
Louder.
Pass,
okay.
pass.
incidence of serous macular elevation and the fluid origin in this optic nerve head disease, which is being depicted here.
Choroid.
Okay, so this is a case of a optic pit. I give you a clue now.
Okay, okay, sir. Okay.
Okay.
Okay, incidence of.
What do you see on visual fields and FFA? Okay. Treatment. Fine, we'll move to the answers. This is a case of an optic dispute, and the commonest location is temporal. 25 to 50, 75% is the incidence, and with the origin of fluid is sometimes believed various hypotheses. It might be a vitreous cavity fluid or a CSF fluid. What do you see on a visual field? Enlarged blind spot. FFA, you might see early hypo at the disc and followed by late hyperfluorescence because of the staining and pooling. And if it is asymptomatic, you just have to observe. But if there is a fluid associated with macula, you can treat it with lasers, intravitreal gas injections, or vitrectomy. Last image. Are you ready there?
Okay, sir. Okay.
So identify the test.
Sir, ERG.
Good. Identify the pattern shown in the figure.
Sir, negative ERG.
Correct. What does it signify?
Negative ERG. It shows the non-functional photoreceptors.
Okay. Name any condition.
CRAO, sir.
Okay, we take it.
Juvenile retinostosis.
Very good. So this was an electroretinogram. Negative ERG was depicted. There was a selective reduction in amplitude of the B wave such that it does not exceed that of a wave. That is how we read. And these are the conditions where you can get this type of a ERG pattern. Well played. So how much do you score? 15. So I think we are over with the sets. Now it's time for us to declare winner. Rolika, your duty.
Okay.
Lalit Verma sir, give it that privilege should be given to Lalit Verma sir and Santosh Onawar sir.
So we do have a tie at the third position, and so we will be considering the marks of the MCQs for breaking that tie, if that is okay. Right. So the tie was. So as per the tie, the third place is was shared by Dr. Pratibha and Dr. Nishant, and as per the MCQ marks.
Be a bit louder, Rolika.
Okay, can you hear me?
Yeah.
Yes, sir. So the third place is won by Dr. Pratibha based on the MCQ marks calculation. Dr. Nishant, you did well too. And the second place is by Dr. Saugata Poddar. And the first place is by Dr. Divya.
Divya, congratulations.
Thank you, sir.
Congratulations to all of them, in fact, for participating, because this was such a nicely designed quiz by Prashant and Shrinivas, and very, very educative, I must say. So therefore, firstly, congratulations to everybody. And obviously, you know, Divya and Savita and Pratibha, they deserve extra applause because of winning. I think this demand that whatever investigation you see, you should, you know, identify that condition don't go into jump to diagnosis. Like in my photic retinopathy, see the outer layer is gone. So then you come to immediate diagnosis, or cysticercosis. Very classical picture has been shown. So don't jump to diagnosis. Otherwise, I think it was very well, conducted, as well as the candidates did very, very well. So only thing is, identify and then jump to diagnosis.
Yeah,
a lot of these treatments may not have any treatment. But questions asked were very typical. You see DME or CNVM or starry phenomena, or EOGs predominantly, fundus autofluorescence. These ought to be known by everybody. There is no.
Ishant wants to say something. He has raised his hands.
He rose his hand long back, so.
Okay. Okay. So I think for every investigation, as Dr. Lalit sir has said, you should try to read the image and then reach out to the clinical diagnosis. There is a pattern how you should read. I think we should have one class where how a B scan has to be read. You have to first read the initials of that particular thing, then what are the parameters used, whether it is standard or not, and then based on that, it's an axial scan. For example, B scan done at 90 decibels of a right eye, axial scan being used, then the initial part is equilucent. That is how an ideal thing should be, we should teach, I believe.
So Santosh, what is the awards for them? First three.
didn't want to trivialize by giving awards, so we just will give certificates.
Yeah. Certificate is a very big award. Right? Certificate is a big award. So must thank Prashant and Sarakshi, Netralaya and Shrinivas for conducting very well.
Who does it, sir? She created such difficult questions, in fact.
No. I think all these residents need to know all of them. I didn't see any question which they didn't ought to know. They ought to know all of them. In fact, I would suggest go back in case it is on YouTube, revise again.
Yeah.
You see, it will help you. If it Santosh, this will be available, no?
Yeah, everything is available.
Yeah, so you go back, listen. Even if you have not performed to your satisfaction, go back and read. You will feel much happier.
That was the whole goal of this quiz, sir, to keep everybody on the same page on a New Year's Eve also. And I really thank everyone for sparing your time on this special day for the quiz and keeping the iFocus legacy alive. And we will see you on the other side in 2022. And with our first session on January 5th by Professor Ian McDonald, and it's on retinitis pigmentosa and allied disorders. And it's an international masterclass coming up.
And wish you all a very happy and prosperous New Year to all of you, all the
And we should
participants.
especially honor Santosh sir for keeping the quiz, especially on the New Year Eve, that too on 7 to 8.
Yeah.
We didn't want to stop even for a day, Shrinivas. It has gone non-stop for the last.
That's the passion.
Yeah.
That's the passion.
No,
Well done, sir. Thanks, Lolika. Thank you,
Well,
Santosh.
Happy New Year to everybody. And
Happy New Year, everyone.
thanks, Santosh. Thanks, Lolika. Prashant, yeah.
Thank
and
you.
Srinivas, bye-bye.
Thank you, sir.
These are two chairmen I see here, Prashant and Srinivas. Chalo, okay.